So if you've tried all of lifestyle modifications, you're taking the right supplements, you're eating healthy, and you're walking more and more and more, and yet you still have leg pain. The Vascular Institute's Dr. Murthy Charmarthy is here to discuss what is next. What do you need to talk about with your doctor? Dr. Charmarthy, thank you so much for being here.
Thank you, Kim. Can you guys hear me?
We can. Just how much do critical lifestyle modifications help in improving or maintaining adequate flow, and for how long? I mean, do you have patients that had 70% blockages, for example, and beyond in their leg arteries, and then they've never needed a procedure to unblock those arteries because they've made such drastic changes?
Yes, I do have, in fact, such patients. Lifestyle modification and the initial conservative management are the important pillars, are the first line of treatment for peripheral artery disease. There are proven long-term outcomes and good benefit. And yes, I do have some patients who present with severe arteriosclerosis, but they were well compensated with collaterals and didn't have disabling leg pain symptoms. On the top of it, they did stop smoking. They underwent supervised exercise therapy and ate all healthy diet like we showed in the past two presentations, which made me hungry. And those patients, they lost weight, optimal weight control, and optimal medical therapy. And those are the patients who, had a stable disease, didn't progress much. I would say right off the bat, smoking cessation is also an important part of that overall management. Of course, again, those outcomes and even how I manage those patients would be different for each patient depending on their symptoms and when they present to my clinic.
So when most people are actually diagnosed with peripheral artery disease, frontline treatment is in fact making those critical lifestyle modifications. So how much pain does a patient have to simply live with though when it comes to PAD? And at what point should they raise their hand and say, hey doc, I'm doing everything you said, I'm trying really hard, I stopped smoking, I'm trying to eat right, trying to walk more, but you know what, doc, it's just unbearable. What do you do?
Yeah, pain is pretty subjective, first of all. But however, again, we try the conservative treatment, and usually mild to moderate claudication symptoms, we should be able to manage it with conservative means. Again, with good optimal medical control and healthy diet, regular exercise. When the pain becomes disabling, it's affecting the patient's quality of life, limiting daily activities, or it's pain at rest. It doesn't respond to any of these prior conservative treatments. I think that's a time when you need to speak to a vascular specialist or your doctor to work it up further and see which direction we need to proceed from there.
And I hear you have a presentation you wanted to talk about more signs and symptoms of, what, where do you draw the line when, how does a person know that they're ready, they need an intervention? How do you know you've kind of gone from that, intermittent claudication to critical limb ischemia, right?
I would be happy to do that. Let me share the screen, I guess. Can you let me know if you see my screen?
Sure. Not quite yet. Click the green button below, share screen, and then you have to choose which one and then hit share.
Okay, give me one more second.
No worries. And we also are going to be joined in a moment again with Dr. Avni Kardani. She is a pharmacist, and she's going to be talking about, as well later on, some of the pain medications that could help.
Perfect. Okay, can you see my screen now, Kim?
I can.
Okay, perfect. Okay, it's a very important question, and I thought sharing a little bit of how I triage the patients who present with pain, and maybe some don't present with typical pain, but maybe atypical leg pain, that would help to clarify the symptoms I look for and when to really consult a doctor. And before I go there, I just saw the program today morning for more than a few hours. I'm really impressed with the whole presentations and how it was packaged together. I think it's just great. It's a comprehensive program, and very glad to be part of it, and for the organization for making me a part of it. Whenever I have a patient who is coming for peripheral arterial disease, usually they present in a few ways. Typically, usually with leg pain, or sometimes if it's an advanced disease, they present with an ulcer or gangrene. So that's your typical claudication pain, which can be mild, moderate, severe. The leg pain can vary in the symptoms, and sometimes it's subjective. And then you have advanced presentation where the blood supply circulation is so bad that it results in end organ damage, and you have an ulcer or a gangrene. However, the classic claudication is not that common. Sometimes patients are asymptomatic, like just we talked before, a patient with severe stenosis but is well compensated by collaterals, and maybe they don't walk much. It's hard for them to know if they have typical claudication. And very small percentage, even though that's increasing. And right now in my practice, the critical limb ischemia is actually part of like 15 to 20% of my practice. But some of the numbers in general, the prevalence is 1 to 2% for critical limb or threatened limb, which includes rest pain and as well as ulcer and gangrene disease. This is how the patients usually present with typical claudication or atypical leg pain, but sometimes you have patients who have just leg fatigue, that they start walking, their legs get tired, and they need to sit down and rest, and then it gets improved. Sometimes it's buttock claudication or calf claudication based on which level of stenosis patient has. And a few times it's, hey, doc, I have very cold feet, I have very cold legs, one leg is more colder than the other, some discoloration. And sometimes the signs might be very atypical, very early hair loss, tingling sensation, numbness, which sometimes can coexist with neuropathy. I do make sure that, that I work up other factors. Sometimes you have a coexisting peripheral neuropathy, and usually this is a disease of elderly, although nowadays I see younger patients who are, especially in smokers, presenting at 40, 50 years, or early diabetics, and so on. But since it's a disease of elderly, usually they have joint pains. You need to exclude joint pains, which can be exertional. You need to differentiate it. And you have other causes like venous claudication, low backache, which we need to differentiate. So I get a lot of history, and that typically tells me, is this pain arterial or is this something else we're dealing with? And again, just like in the morning, we had several talks and we had few patient questionnaires, which were amazing. So sometimes it's important to know the natural history, right? If a patient presents with very mild to moderate stable claudication, most likely they will do okay if they can stop smoking again, do those 3-4 pillars of conservative management. And if they have worsening claudication or they progress to rest pain and have ulcer and gangrene disease, it becomes very important that we intervene at that point. Again, this is the typical protocol I do. Anytime patient comes, healthy diet, weight loss, smoking cessation. Smoking cessation is not proven to reverse the effects, but it does arrest further progression of the disease. And I think it's a very important step. And even after treatment, if patients do not stop smoking, it negates the effects of my intervention. They come back pretty quick. They come back early for another reintervention. I do start, statin therapies, antiplatelet agents, and ACE inhibitors as appropriate. We do have some good medications, very great medications, cilostazol, pentoxifillin. Cilostazol is an amazing drug. Exercise therapy, right? Whether it's medical therapy or whether it's intervention, including a supervised exercise therapy has proven to be of better benefits and outcomes. And again, when do I consider an intervention? When it's severe symptoms and it's affecting patients' daily activities or quality of life, and patient tried conservative treatment and it failed, or if they have disabling rest pain that's preventing them to do anything, or if they have a slow or non-healing refractory arterial ulcer, gangrene, or cold leg. This is when intervention becomes important to treat these patients. So I think that's a short presentation. That's all I have. We can talk more, but.
Yes, we have actually a question that just came in from Steve Eldridge. He says, Dr. Charmarthy, I had a recent bypass performed a month ago. I have no pain, but extremely tired all the time. Is that normal? And is there anything that he can do about it?
Yeah. So yes. So you shouldn't feel tired if you felt better after a bypass, and now if you have, and I'm assuming that it's a fem popliteal or a fem bypass. You're talking about a bypass in the legs. That's what I'm assuming.
Yes.
It's if you felt better after the procedure, and if you feel tired now, that's not the way it should be. I would definitely probably get a CT angiogram, which is a 3-second scan, unless you have any, kidney failure or so on. You can get the dye and we can image and evaluate the bypass. And the first thing that comes to my mind is, is the bypass working properly? And I think that CT will give us more information. Of course, a physical exam will give me more information to see how your pulses are downstream in your feet. And I think the temporal relationship and imaging will add benefit. And if we see any narrowing, we can definitely fix it.
Sarah has a question. How much pain should I expect after an intervention? I get that I'll likely have a few days of discomfort, but I think this is two parts. One, directly following the procedure, as the blood flow repopulates my feet, it was painful for almost a week, but then it got better. And now, number two, I still have that heavy feeling in my legs. The pain is not as bad, thankfully, but is still enough to say, hey, I'm here. Will I ever be pain-free? Is it even possible?
So that's a very, very good question, actually, because it happens very often. So Sarah, I think so most of my patients, they do have some mild discomfort post-procedure, usually for a few days, and it should get better. And also it depends on what kind of approach, how aggressive I've treated them. For example, I do pedal approach and pedal interventions like we showed in the morning. Some speakers spoke about it. And in those cases, the recovery is very quick. Like patients walk home after like half an hour to 1 hour after my procedure without much complications. Sometimes your feet and your legs, they get good blood flow now, which they didn't have for years, and that can cause some pain and soreness. We call it reperfusion injury. It happens in other parts of the body too. But it also should get better in a few weeks. I usually give some pain medications during that time, and usually I expect that it should take care of it. And sometimes patients who especially have complete occlusions, and once I recanalize and open them, they do have leg swelling for a few months. And that's also pretty common, and I just treat it conservatively. Usually after a few months of conservative treatment, it gets better.
And Bob has a question. I'm certainly not an expert researcher, and I admit I spend way too much time on Dr. Google. Gosh, I've had throughout this conference, a lot of people have mentioned Dr. Google. But after Kim, me, I guess, talked about a new trend in doctors using lower pressure balloon for longer periods and it causing less trauma and fewer stents, I did find a couple of doctor articles on it and found it interesting. Why aren't all doctors taking this approach? And how can I talk to my doctor about making sure this is their preferred method? Will they get offended? I mean, I'm a scientist in my past life, and it just seems logical to me when I think about the stretching of a rubber band and it snapping back. That's a really good analogy, actually.
Yeah, so yeah, very good question. I think I don't hold any stocks in Google, but I think you should buy the stocks, not do the Dr. Google, which can sometimes confuse you. But yeah, very good question. Typically, we use very low pressure balloons by default. That's the standard of practice. Low pressure balloon, inflate for 1 to 3 minutes, and thereby you can get very good optimal results and less complications. That's how we treat the arteries in the legs, and it just makes sense from every physics, hemodynamics, every standpoint. Actually, when we do balloon a vessel, what we are doing is we're creating a controlled dissection. So what is important is to accurately size the balloon to the vessel. You don't want to oversize it, you don't want to undersize it. So as one of the speakers showed in the morning, we use a camera sometimes which visualizes the interior of the vessel. We call it intravascular ultrasound, and that helps us to accurately size the balloon and use appropriate size to get the best outcomes. I think it's a very good. There's a lot of research, and like I said, it's the default. Anything else is probably not the standard of care. And added to that, we have a lot of new technologies now. We do have some promising results from intravascular lithotripsy, and we do have so many newer things coming up, cryoplasty, drug-coated devices. So I think there is a lot of improvement in trying to be accurate and trying to get the best results, right, and low risks. And it's always a balance, but we're trying to tilt the balance and get even more out of it.
Pain medications, you mentioned, quite a bit. They're really the most discussed actually with, patients around the world. We see it all the time when it comes to especially peripheral artery disease pain. So I want to loop in our pharmacist again, Dr. Avni Kardani, who's also with the VA in the San Francisco Bay Area. Dr. Kardani, thank you so much again for being here. Before we get into you though, I'm curious, Dr. Charmarthy, what are your go-tos for pain meds for PAD, and when do you most prescribe them?
Yeah, just on a side note, like for everybody, pain is painful. So I do, usually I reserve pain medications for severe or disabling pain. I use both non-opioid and opioids. The way I prescribe these medications is based on the level or severity of the pain relief potential of those medications, and the risk for addiction. It depends on a case-by-case basis. Is it preoperative? Is it postoperative? Is there an underlying ulcer? Is it rest pain? I usually use a lot of cilostazol, which gives very good results for claudication. I use gabapentin for peripheral neuropathy. I use them pretty frequently. And for pre-op and post-op, I use non-opioid as much as I can, and some opioid medications.
So, what works really when and for whom, before procedure and after procedure?
Usually, again, severe ischemic pain or ulcer pain, they need more stronger medications, and you need some opioid medications. Post-operative pain, especially for endovascular interventions, is usually mild, and it requires just over-the-counter medications, unless there is a reperfusion pain, which we talked about, or unless there is a procedure complication like a cold feet or something, then you need to be aggressive with those pains. And sometimes you might need hospitalization and pain control too, if it's a very bad ulcer or a cold leg.
Dr. Kardani, what do you see most prescribed for people with neuropathy? Is probably the one that you see the most. Opioids, according to several doctors I spoke with, are really not used in their practice, actually, thank goodness. One I see a lot though from patients is gabapentin. Is Dr. Kardani still on? Is that something that you prescribe a lot, Dr. Charmarthy?
Yeah, I do give, I don't know if we can, I think Dr. Kardani's mic is muted, I guess. I think I can see her, but yeah, I do give a lot of gabapentin, it's, in my experience, it's a hit or miss. Patients either get good relief or sometimes I escalate the dose and it doesn't work at all. But I will leave for Dr. Kardani to discuss more or add on it.
Yeah, I agree with you, doctor. As far as gabapentin by itself for pad pain, it's a hit or miss. Some patients, it responds, really well to their pain, and then some patients, they don't feel any improvement whatsoever. What I have seen, first of all, when you have PAD or you diagnose with PAD, your doctor is going to put you on an aspirin, whether it's baby aspirin, 81 milligrams or 325. That's also going to help not only thin your blood, but also going to help you with a little bit of the pain aspect of it. Another drug that is going to help with that is clopidogrel or Plavix. So that's, it's thinning the blood, and that's what's the main issue is in PAD. So that helps with pain as well. One of the big drugs, as Dr. Charmarthy mentioned, is cilostazol. I see a lot of patients on cilostazol. And what that does, it basically increases walking distance for patients, right, who have intermittent claudication. It increases the blood flow to your limbs, both by keeping the blood thin, and also it makes widens the vessels, right? So that's where that's how it's helping with the pain in PAD. Another drug that I've also seen, one thing I really want to mention is the cilostazol generally is not given to patients who have history of heart failure, right? So that's one thing that if the patients have history of heart failure, that drug is a definite no, it's a contraindicated medication. So another drug that I've seen is pentoxifylline. Pentoxifylline has also been used. It's an older drug, but it has worked. In theory, it causes the red blood cells to become more flexible, right? So they kind of slip past the blockages in the arteries and improve the blood flow in the limbs, and that's how that also helps with pain. So those are the two main drugs that I've seen prescribed to patients in peripheral artery disease to help with pain initially. And even cilostazol and pentoxifylline also help even after revascularization, right? It'll help you, for a little bit of time until you don't need it anymore. I have seen gabapentin and pregabalin, which is basically just like gabapentin. The only difference is pregabalin is a controlled substance somehow, and gabapentin is not. But in neuropathy, like if you have tingling or pins and needles, stuff like that, that really is addressed by gabapentin and pregabalin. That helps really well in critical limb ischemia. There's some studies out there that have shown improvement with gabapentin. With the dosing, that's something that patients need to really, be careful with gabapentin. The ER formulation is generally titrated, so you're going to start with a low dose. 3 days, you're going to increase dose. 7 days, you're going to increase dose, and then eventually you're going to be at your stable dose level, right? One thing to always keep in mind with gabapentin and pregabalin is do not stop taking it abruptly without telling your doctor because there's a high risk of seizures if you just stop it. Unless you're in a really low dose, then it's completely fine, but generally you don't want to stop it. So those are the main drugs that I've seen. I have not seen opioids unless it has, like Dr. Charmarthy said, unless it is post-operative pain, right? Then maybe for 7 days, up to 7 days, you can, have it. Use it as needed. And once again, lowest dose possible. And then if the patient is not opioid naive, then of course you're going to need a higher dose and whatnot. But I think the main thing with opioids is you want to follow up as soon as possible. When do I stop? Generally, your pain goes away, you stop, but some patients it's difficult for you to stop, right? So if it's just for acute period of time, just for post-operative, 1 to 2 weeks, generally that's all you need it for. So at max 4 weeks, you want to talk to your doctor if you're going to be taking it for that long, right? For chronic therapy, generally you don't want to use opioids if possible. NSAIDs are really good with inflammation and with pain. So I would suggest generally just stay with ibuprofen or naproxen or something like that. If you do need to give opioids, for chronic therapy, no more than 2 or 3 months, you want to, recheck them and once again, don't use them as much as possible.
Kardani,
like Dr. Charmarthy said.
You have a rule of thumb, when it comes to being on pain meds, but actually even all meds, patients should have a scheduled next visit, right? This is something that I think is very important. We always, talk about follow-ups for, procedures, things like that. But if you're on any drug, you actually said that you believe that there should always be a regularly scheduled follow-up just to discuss what drugs you're on, what they're doing, if they're working, etc.
Right. If you are actively working with a physician on a particular issue, so for peripheral artery disease, you want to check with your doctor for pain. Generally, they're not going to give you opioids, as I mentioned, but you want to check in with them about 3 months or so after you have done a procedure. I mean, they're going to tell you exactly when to see them again, right? But if you're only on med therapy, you're doing lifestyle changes, then every 6 months to a year, you want to follow up with them.
And any, side effects, things like that you want to discuss with all these pain meds, statins, everything vascular. I mean, are there any warnings such as with the potential for heat stroke, or any contraindications with taking, we talked earlier about turmeric or other supplements that you think is really important to mention?
Right. So as far as the medications that we discussed today for pain medications, heat stroke is not an issue. Maybe with opioids, because you're going to get that dry mouth, or if you're on a muscle relaxant or something, you're going to need more hydration. So as long as you're well hydrated, you're fine with that. Some medications, however, for like PAD, for example, if you're using calcium channel blockers to control blood pressure and heart rhythm, etc., some of them may increase the risk for heat stroke. So that you want to watch out for. If you have PAD and you're taking some of these medications, then very likely you are probably on a beta blocker or a calcium channel blocker as well. So that can potentially increase the risk for heat stroke. And said, like ibuprofen, naproxen, like as we were talking about, they're available over the counter, but they also increase the risk for heat stroke. If the patient's on diuretics, like a Lasix, like a furosemide or hydrochlorothiazides, those are medications that also potentially increase risk for heat stroke. But as far as the medications that we discussed today, there's no specific risk for heat stroke with them.
It's interesting you mentioned the, Dr. Charmarthy mentions the fentanyl, the lidocaine patch. How often do you actually prescribe patches? Because in all the patients I've talked to, I've had maybe one patient have their doctor just prescribe a patch, and I would think it would be a good, temporary at least solution, even in the middle of the night especially.
Yeah, not often. Sometimes in some occasions it helps, especially for local pain. Very superficial local pain, but I just mentioned it for completeness sake. I do in fact use nitro paste more often, which is nitrobid 2%, especially in patients with critical limb ischemia, to vasodilate and provide some local relief while we plan to do any procedures or aggressive interventions. But patches are, I don't use them that commonly.
But just in wrapping up here, but really the key when it comes to any pain medication, there's a cause. You have to, right? There's a cause for this pain. It's really important that when your doctor prescribes a medication, stop for a second and say, hey, wait a minute, doc, let's figure out what's causing it and address that. And especially if they're having life-limiting, I hear Dr. Kardani agreeing, I mean, especially if you're having the life-limiting, claudication, you have rest pain at night, I mean, then doc, right? It's time for intervention. You got to get that blood flowing, even if it's just pearls, right? You got to get that blood flowing. That'll help get you some relief. And you got to do that sooner rather than later.
Absolutely.
Any final thoughts?
Yeah, exactly. And that's why drugs like cilostazol and pentoxifylline are more appropriate in PAD than opioids, right? Because they're actually not just relieving the pain, they're actually trying to help the underlying issue, which is to improve the blood flow. And that's the reason why I would not recommend opioids. Or I know, Kim, in the past you mentioned CBD or medical marijuana for pain and inflammation as well. The studies are very, still basic. At this point, there's no definite improvement that has been shown in heart disease or peripheral artery vascular disease with CBD. It does have anti-inflammatory property, and it does do vasorelaxation, right? But other than that, to specifically say, hey, I have PAD pain, CBD is going to help me, that's not something that I would agree with.
And so one more here from Julie. She asked, what helps with leg burning? Hers are always on fire. I hear this a lot. She says, gabapentin does not take it away. If both of you could share your thoughts of what you normally do in here.
Yeah, so for gabapentin, it is, it is taken in a variety of doses, right? I mean, you start with like 100 milligrams 3 times a day, and then you go up all the way to 3,600 milligrams per day, right? So if the particular dose is not working for you, you may benefit after talking to your doctor to increase the dosage. Another thing with gabapentin and pregabalin both is that if you have renal or kidney issues, then the dose is going to have to be adjusted, right? So to make sure that you're not taking maximum dose if you have kidney issues. Sometimes you might have to even, inform your physician if they're not aware of certain things with you, right? Another thing I wanted to actually mention with gabapentin, I forgot, is the suicidal ideation, right? So it's a major side effect of gabapentin. It can cause depressive state. So you want to monitor that if your doses are changing, and if you're just newly starting the medication, just be mindful of that.
Thank you so much, Dr. Kardani. I really appreciate you so much. And she's in all of our groups, so you can always tag Ask a Pharmacist, or Ask Dr. Kardani, I think is the tag for her Facebook page, which is Ask a Pharmacist. Thank you so much. And Dr. Charmarthy, thank you as well with the Vascular Institute. We appreciate you. Is there any way that people can reach out to you in case they have further questions?
Yeah, absolutely. Thank you, Kim. Again, it's an honor to be on this conference, and absolutely, they can reach out to the Vascular Institute of North Texas, or they can reach out to me at drcharmarthy@yahoo.com. I would be happy to get back with any answers. Thank you.